Another area that's been really exciting has been the development of IDH inhibitors. What's very exciting about that is how the science really drove the clinical therapeutics. The discovery of IDH mutations happened, as recently as 2008 from whole genome sequencing of AML. This was not recognized at all to be a recurrently mutated gene in cancer. And within a decade, there's not one but two drugs that have been FDA approved to target that mutation. And these drugs have really led to substantial improvements in the likelihood of pretty reasonable survival durations with, again, pretty good blood counts for patients that were often at the end of their rope in terms of exhausting prior therapeutics or really weren't good candidates for other therapies. IDH mutations increase in incidence in older patients, and some of these patients are frail and not good candidates for intensive approaches. The IDH inhibitors have been generally well tolerated. It's not to say they don't have side effects. We do need to watch for differentiation syndrome. There can be issues of EKG changes on ivosidenib with QT prolongation that need to be monitored. Doesn't mean that this is a deal breaker, but it just requires warrants close monitoring during therapy. But really, patients on these drugs can do quite well in terms of response rates, and the survival among responders has been really good, with median survivals of 1 or 2 years on these studies for patients who go into remission. And we see remissions in about 30% of treated patients. So those are pretty good numbers in the population that this is targeting. And one nice thing is we can actually look and see who benefits from the drug by looking to see who has the mutation and know that those are the patients who should get this treatment. This is not a one-size-fits-all treatment. We don't expect this drug to have, or these drugs to have any activity outside of the mutation itself. It really is a nice example of precision medicine benefiting patients.